Now let's discuss about ovarian cyst. Ovarian cysts mostly are of three types. One is follicular cyst, the second one is corpus luteal cyst, and the third one is theca luteal cyst. The most common one is follicular cyst. How it develops means the pathophysiology. It is actually due to the failure of mature follicles to rupture at follicular stage of menstrual cycle, means day 14 most commonly. The corpus luteal cyst, it is usually, this is a corpus luteum and it is surrounded by a granulosa cell layer. How it develops, it is usually mostly due to failure of involution. Corpus luteum at end of luteal phase of menstrual cycle, means day 28 in most of the patients. This type of cyst can be converted into hemorrhagic cyst because the granulosa cell layer is highly vascular, and sometimes this vascular teeny teeny vessels ruptures and the bleeding accumulates inside the cyst, in which case we call it hemorrhagic cyst, and most of the hemorrhagic cyst can be managed conservatively depend upon the patient status. Thicker luteal cyst is due to excessive HCG stimulation of theca internal layer. Now, the excessive ECG can be due to multiple causes. One is ovarian hyperstimulation syndrome, molar pregnancy, gestational trophoblastic diseases, multiple gestation, diabetes mellitus, polycystic ovarian syndrome, etc. What are the risk factors for ovarian cyst? Risk factor is one is smoking, second one is progestin only pills. If the female patient taking progestin only pills as the contraception, then this patient will have high chances of ovarian cyst. But one thing should be remembered that combined oral contraceptive pills usually protective against cyst, protective against ovarian cyst. Okay. The third one is there are multiple causes tamoxifen use. Okay. What are the complications of this? The two complications if the with the female patient has the ovarian cyst, the two complications most likely occur. One is the torsion and the other is rupture. Torsion and the other one is rupture. Torsion will be the previous history of o- ovarian cyst, and now the patient came to the OPD with nausea, vomiting, pain, and fever. You will suspect ovarian torsion, especially lower abdominal pain with nausea, vomiting, and fever. And rupture, there will be peritoneal signs like guarding and with distension. So, female patient in the past, she has had ovarian cyst and now came with the peritoneal signs like guarding distension. You will suspect ovarian cyst rupture. Now there are some indications for surgery. What are the indications for surgery? One is the size more than or equal to 5 centimeter. Uh, but in some book says it is more than 7 centimeter. Or increased size on follow-up. For example, female patient having 2 centimeter cyst, and after 4 months of ultrasound now the cyst has 4 centimeter. This patient also needs surgery. The second one is ultrasound suspicious of malignancy. There are some certain ultrasonic features which can differentiate that the cyst is benign or malignant. What are these features? One is benign, usually unilocular, while multiple is usually malignant one is usually multiloculated. Okay, there will be no ascites, but there will be ascites. There will be no lymphadenopathy, but there will be lymphadenopathy. Okay, there will be posterior acoustic shadow. I will show you what this means. Posterior acoustic shadow, but there will be no posterior acoustic shadow. Okay, there will be no blood flow in the cyst. Means if you do the Doppler for this patient, the Doppler will be negative. But in this case, there will be blood flow to the cyst and the Doppler will be positive. Okay, this is usually, the benign one is usually unilateral, while this one is bilateral. As it is single and thin septation, means the septa are should be less than 3 mm, while in this there will be thick septations more than or equal to 3 mm. Okay, if the cyst has papillary structures, then in malignant the papillary structure should be equal to or more than 4 papillary structures. Like this is a cyst and there is papilla. So in malignant this should be more than 4. Okay, these are the benign versus malignant features. Like you can see in this case that it is a benign one because this is the posterior acoustic shadow, this one. Okay, it is unilocular hypoechoic cystic. If there is solid component in it, then it will be a malignant. Yeah, like in this case, like in this case, this is malignant. Why? Because of the multiloculated with thick septations, okay, and there is solid component, this one, okay, and you can see that on Doppler ultrasound there is blood flow. It means this is malignant, and these are the papillary projections. Okay, that's all about the benign versus malignant features of ovarian cyst on ultrasound pictures. One of one of the indication was size. Second was the increasing size. Third one is the ultrasound features of malignancy. If any one of these, then you will proceed towards surgery. The fourth one is patient presented with acute abdomen, like either target or rupture, then you will go for surgery. Now the surgical options are, what are the surgical options? One is the cystectomy, ovarian cystectomy. This is most commonly performed procedures for ovarian cyst. In the past, we will- in the past, the, the surgeon did aspiration, but this is now not used most commonly because of the recurrence. Okay, and if the female is postmenopausal and there is no need of fertility, then you can do salpingo oophorectomy. Okay, if second, the last one, the last, if a patient came with the ovarian cyst with malignant features like multiloculated ascites, lymphadenopathy, blood flow, all of these, one or more than one of these is present, then the patient should do CA 125. If this is greater than 200 unit per milliliter, it means this is a malignant and needs further investigation for completion. Okay, that's it. Thank you.